Today's episode is powered by Listen, a groundbreaking AI platform transforming how child welfare and other public sector providers learn and grow. Imagine being able to roll out comprehensive, secure training and quality monitoring across your entire organization instantly. That's exactly what Listen delivers to over 70 public and private sector clients. Developed by PhD academic psychologists, Listen helps health and human services agencies master motivational interviewing and other evidence-based practices. And this isn't just another training tool. It's backed by 16 years of rigorous research and peer-reviewed studies. To learn more, visit listen.io. That's lyssn.io. lyssn.io. Or follow the link in the show notes.
Hello and welcome to the Imprint Weekly Podcast. I'm John Kelly, Senior Editor of the Imprint, a daily news site covering child welfare and youth justice around the country. You can read all of our coverage at imprintnews.org or check us out on Facebook or Twitter at the Imprint News. You can also sign up on our homepage for our free weekly and monthly newsletters. And for professionals in child welfare and youth justice, subscribe to our Youth Services Insider section for a closer look at news on business policy and practice. The Imprint Weekly Podcast is also a member of the Safe Camp Audio Network. Check out our show page and all of Safe Camp's other great podcasts at safecampaudio.org on the web, at Safe Camp Audio on all your social media. On the last episode of the Imprint Weekly Podcast, we had Zach Laris of Boulder Horizon, he's also the author of the Child Welfare Wonk blog, on to discuss the role Medicaid plays in preventing child welfare involvement in managing the health of youth in the system. And after it, obviously, that conversation is very relevant to the discussions going on at Capitol Hill around potential cuts to the Medicaid program. Today, we are going to feature another expert in the world of Medicaid, and that is Alex Briscoe, who is one of the principals at Public Works Alliance, for a more free-form discussion of this entitlement as it relates to, in particular, children's mental health. Briscoe came up in youth-serving organizations. I think his first full-time job was at a school. Eventually went on to lead mental health and family services in Alameda County, that's Oakland, California. And just recently wrapped up a chapter of his career where he led the California Children's Trust, which is a multi-year initiative aimed at rethinking what a mental health response for kids even means, and at the same time, increasing how many children were screened and served in California. So we talked a lot about that adventure, that last one, what went well, what was left undone by the end of the California Children's Trust, which sunsetted last year. But before we dove into that, Briscoe really just talked aspirationally about what mental health services should look like for kids in this country, really stripping out all the Medicaid talk and entitlements and alphabet soup of organizations and just really getting to what it should look like. And then we talked about, how his various leadership positions have informed his views of why reality does not match his vision. And of course, towards the end, we talked a little bit about what's going on in Capitol Hill with budget reconciliation. And he shared what he thinks are the most dangerous cuts to Medicaid that would impact youth and families. So without further ado, here is our conversation with Alex Briscoe. Alex Briscoe recently wrapped up his time helping to lead the California Children's Trust, an effort to reimagine everything about the way California approaches paying for and delivering mental health to its millions of children, or most of those children. When I asked him recently what he was doing next, he said, I'm going to do big stuff that matters with people I trust and admire. He joins us today to talk about that big stuff, a little bit about the legacy of the Children's Trust, and more generally, the moment we're in with children's mental health and Medicaid, two topics very much on the minds of Americans today. So, Alex, thanks for joining us on the Imprint Weekly Podcast.
Oh, John, thank you for having me. Thanks.
I can't believe we got to episode 200 and whatever we're on without you being here. Actually, it's a big flaw on my part. I should have had you on earlier.
I'm not offended, brother. I'm not offended at all.
So house rules here, we got to get them to know just a little bit about you before we get into the weighty stuff of the world. So I'm going to ask you to give me one favorite out of these categories: movie or TV show, musical group, book, or sports team? You can give me all of them if you want. Just got to give me one. What do you got, Alex?
Oh, geez. I mean, I'm a Lord of the Rings guy.
Lord of the Rings guy. There
Yeah.
it is. Okay.
Standing in the breach with the flaming sword of justice. What else is there?
That's excellent. So let's start before we get into some specifics about your career and your thoughts on mental health for kids and all this stuff. What is your vision for a child mental health system in this country? Take it, and I want to challenge you to take it from a first point of contact to the deepest end involvement with a family. What should be the experience of a kid and his family in this space?
I love that question. And I know you're asking me this question free from the restraints of culture and resources. Like you're asking me, what could it be if it was how it could be? Yeah.
Yeah, I'd almost say like don't use the terms like Medicaid and things we're going to get into. Just what is
Absolutely.
your vision for how kids and parents should just experience what we would call a child mental health system?
Love it. I mean, very succinctly, social and emotional support would be woven into the lives and experience of children and families where they live, work, and play. And the current medical model constraints that define the existing practice of mental health would be a very small component separated out. And what this looks like in practice is from conception through delivery and early childhood development, caregivers would receive support from the clinical community that they interact with on the physical health side, but also from a community of people with lived experience who would guide their social and emotional health and support their social and emotional health in what I would call social model programs. So what this might mean is from the minute you get pregnant and decide to procreate, someone is asking you how you're feeling, what's working for you and what's not working. And it's not necessarily a clinician, it's someone who shares your lived experience. That person is articulated to clinical supports, but your experience is intermediated by someone with traditional clinical training. And then as you go through the process of procreating and making a baby, you would find care and connection from people with relevant lived experience at every step of your journey. And then once your baby's born, when you take them to the doctor, you would get support from, again, people who might look like you or share your lived experience, who are connected to clinical supports if in the relatively limited needs you might have in that way, you can get it. And then once your kid is going to school or going to a community center or playing on their playground, those spaces would be infused with supportive social and emotional content that celebrates and honors your experience and lets you feel seen. And then as you age into school age and early adolescence, you would be taught how to resist the toxic messages of this culture. You would be encouraged to find purpose and connection. You would be taught the skills of relationship. And then as you became an adolescent, you would get a chance to explore your purpose in the context of folks supporting you, again, who have relevant lived experience and connected to clinical supports if you needed it. And then by the time you were a high school or in college, you'd be thinking about the ways that you could support other people's growth and development and social emotional support. And it wouldn't be something that you would do as a professional or career. It would be part of the air we breathe as a culture. That we're mutually accountable for the context that we live in. Man, I could keep going. I'll stop there.
No, I really appreciate that. And I mean, I think one thing as I was kind of listening to you lay that out that really struck me was it's aspirational for sure, but only in the sense of coordinating in any way. It's all things that exist, you know? Like you didn't say anything we need to invent there.
Man, John, thank you. Like what I almost always say in the systems I work in is that people know how to heal. They know how to connect. It's just so very rarely do our public systems pay for it.
Yeah. Let's talk about that a little because, you know, this vision that you have now, I'm sure was shaped by many years of actually being in the trenches in this system you led Alameda County for non-Californians, that's Oakland and areas nearby. There are children's services, right? And then the healthcare system right after that. So like, how did those very formative experiences, I'm sure, shape your vision? Like when you called it a medical model earlier on, like what does that mean, and kind of what did you learn on the job that now kind of shapes your view as a reformist?
Well, I'll go back even a little earlier. In the community I grew up in Philly, I started a charter school with a bunch of friends. So actually, I was a peon around a bunch of amazing people who started a charter school. I literally plunged toilets for that program and did other things, swung a hammer. But the reason I tell that story is I learned very early on is that young people are brilliant. If you give them good information, they'll make good decisions. Then I became a therapist in the Oakland public schools. I worked in, predominantly African American high school in West Oakland, and got so many lessons there. I have such a deep debt of gratitude to West Oakland and that school community. Early on in my career there, a young African American mother said to me, "Get your help up off me." And I'll never forget that, man. It was like just the sand shifted beneath my feet.
What were you trying to do? What was the incident?
I was trying to help her teenage daughter. She must have had that, she was a young woman herself. And the next thing she said was, "I don't need another referral,"
right.
which I love too. To answer your question, that experience from Philly to Oakland to then working for the Children's Hospital in high acuity settings to working in juvenile detention and foster care and then leading a public system. I think we've designed these systems for the people who work in them, not for the people who need care in them. And at almost every turn, we hunt for pathology. We don't celebrate the adaptive capacities and the beauty and the wisdom. And I'm not trying to minimize suffering. So like, for all these people who've never seen suffering and talk about resilience, nah, okay? I've seen a lot of children die, but I don't really remember that. What I remember is like the flowers their parents gave me. Like, I think what I have learned, despite all the human suffering I've been around, is that people are awesome. That young people will survive and thrive if we give them a chance. But I think we're doing it wrong. I think we are imprisoning young people in their problems. And, a really important lesson of therapy is you don't stop a behavior, replace it. And I think that we haven't done enough to sort of celebrate the beauty and wisdom of young people and mine their experience for the things that work for them. Like every young person I know is an artist. Like they're making beats, they're doing t-shirts, they're a poet, they're expressing themselves. Why do we deliver mental health services in 50-minute psychotherapy sessions with a closed door? That's not what young people are asking for. That's not what has proven efficacious. Like, where's the joy? Where's the connection? Where's the link to the things that they find relevant and important?
Yeah, and to like triangulate your two kind of assertions there, that it's driven by pathology and it works for the people in it. To kind of bring those together, why is it, holding those to be true, what is it about pathologizing that is good for the workforce as opposed to the client in that case?
Yeah. Well, and look, just to be, before I say what I'm about to say, which might be perceived as harsh by your listeners, I don't believe there's bad people. I think people are doing the best they can with what they've got. But this model of care that I was trained in and that we're delivering is very much culturally bound by, generally white folk of privilege who developed it. It's fact, So it was developed in this way that we justify care by identifying dysfunction. Just look at what you have to qualify for care. You must meet specific criteria in the diagnostic and statistical name. Now, luckily, we just changed that, John. So I just want to say, one of our biggest wins was we removed diagnosis as a prerequisite for care. But historically, we have this belief that like more people are going to flood us with all of their problems, so we must restrict what they get by sending them through this narrow crucible of a diagnosis. And that turns out to be inaccurate and potentially racist. I think it is racist, but that's my own experience. 80% of the poor kids in California are kids of color. Between 60 and 70% of licensed clinicians are white. I like white people. We're cool. Okay, we got a role to play. But we know from 50 years of research that when you're treating professional shares your lived experience, the outcomes are always better in heart disease and cancer and in behavioral health. So these systems that we've created actually shamelessly profit on human illness and suffering. I mean, anybody who says different ain't worked in it, Sorry. Like, so we have to change them, grab them, and reform them to be more kind and relevant.
I mean, you have overseen some of these workforces. Is your sense and your experience from that time, and it's not like you've been a few years separated from that, and you're working kind of bigger picture now, but you interact with as many people as anybody I know in this space of child welfare and mental health and all these things. I mean, is your experience that the people within these systems know what you're saying is true, agree with you on it, and feel trapped, or they feel comforted by the system that's controlled through that route of
yeah. I don't think anybody thinks it's working. The state just spent $10 billion on it. Like, for years when I was leading a system, I would go up to the state and be like, state, I'm a dutiful county executive. This shit doesn't work. Okay. Like, are you sure you want me to do it this way? And the state would always say, Alex, go back to Alameda County and work harder. Okay. It's delightful that we, elected a governor who hired the best guy we got, Secretary Mark Galley, and they said, oh yeah, the nation's largest Medicaid program sucks. We got to change it. That's what CalAIM is. That's what the Youth Behavioral Health Initiative was an unprecedented investment and recognition that it wasn't working. And it's hard to unpack and undo 50 years of bad policy. None of this stuff is going to change overnight. But lest we not acknowledge and celebrate, we finally had some leadership who stopped telling the world that it was all okay.
Yeah.
And I for one, I'm grateful for that. But to your question directly, no, I don't think, I think it's fair to characterize the youth mental health system this way. Most kids get nothing, and those who do get the wrong kind of service too late, often in very restrictive settings. And that's really the kind of opportunity for reimagining ahead of us, is how do you reimagine mental health as a support for healthy development, not just a response to pathology?
Right. Which is what you guys tried to do in California. It sounds like maybe I'm gonna guess you're gonna give me some things you felt good about and some things you felt were left on the table here. But the California Children's Trust kind of came out of an opportunity, and I'll link to some of our stories at the imprint that we wrote as this kind of arose. But where there was revenue was good in the state, there was a chance to get some new waiver authority from the feds when it came to Medicaid.
Yeah.
My sense was always built around, you described it to me early on, it's like two prongs. I know there's more prongs, but these are the ones that stood out to me. Getting California to live up to an obligation called early and periodic screening, diagnostic, and treatment, EPSDT for people that know Medicaid, and then rethinking the universe of what could come out of that screening. Is that accurate to say that is kind of the core of it, or?
I feel heard. Yeah. I mean, there was some, healthy dose of race and class and, trying to get at systems architecture and how they work together, and a lot of finance, but you framed it well. I love it.
So you just referred to the latter part of that, basically successfully moved California off of the sort of diagnostic gatekeeping. Can you expound on that a little bit? Like, what went into changing that, and what did that tangibly in practice so far?
I mean, I thought this was sort of a symbolic thing and was going to be little, but talk to anybody like me who's done a lot of mental health and Medicaid, and we all joke about adjustment disorder not otherwise specified. all the tricks we used because, the hundreds of millions of dollars of Medicaid mental health I've done, I'd say maybe 20% of those kids were mentally ill and 80% really bad stuff had gone down. Mom had been arrested or dad got beat up or, kid got beat up or worse, right?
Yeah.
And having to diagnose those kids was, to generate a paycheck for a professional class that didn't mirror the beneficiary class was problematic for all of us working in the system. None of us thought that was right. And then Dr. Nadine Burke-Harris repopularized the ACEs study from the 70s. And I know there's a lot of should we screen or not screen, all that stuff. But look, let's honor Nadine for the incredible leader that she is. She created a way for us to talk about racism and poverty in the context of health outcomes. That's what, I'll sometimes joke, John, Nadine gave me a way to talk to white people about racism in a way that didn't activate them. Adversity is cool. Structural racism is not a thing you can say. But so basically what we did is we just followed Nadine into the abyss, man. She kicked the door in. And now she didn't fully understand the reimbursement, and that is one thing, John, I need to say. Me and the trust, we were focused on reimbursement policy and practice. And I would just say to the advocacy community out there, if you want to change how shit works, change how the money flows.
Right.
It's just, you're not paying for it, you're playing with it. And so through Nadine's leadership, we saw this opportunity to look at the idea that you don't have to have measles, mumps, or rubella to get a vaccine. Why do you have to have a diagnosis to get access to mental health? And she gave us the language and framing to get it through. So to make a long story short, what we did was we aligned access criteria in Medicaid to the true drivers of the youth mental health crisis. So twice as many kids.
To be clear, you're saying that the things that might increase somebody's ACEs scores are those things.
Absolutely. Look, man, between the decade before the pandemic, 2007 to 2017, we saw a 104% increase in hospital admissions for self-injury. So literally, twice as many kids. Rady Children's Hospital in San Diego, a big level 1 trauma center, went from 6 kids a day to 53 kids a day in psych emergency.
In what years? What years range was that?
2007 to 2017 is the self-injury data.
Yeah.
The 1,700% increase in ED utilization and rabies, I think I have to check me on this one, 2005 to 2018. Yeah, recent. Okay. Yeah. But the point is, no reasonable epidemiological analysis points to the fact that there's no reasonable explanation that suggests twice as many kids got twice as pathological. We didn't spike the water, right? Something about our culture makes kids despair. And it doesn't take a lot to know what it is, John. We took the most toxic messages of our culture, the same ones that this culture has been selling for 400 years, that women can't be president, that fame is merit, that wealth is value, that Black people aren't as good as white people, et cetera, et cetera, et cetera, that children are sexual objects. We put that in the eyeballs of our children in 2009 when we made the internet available on mobile platforms. And it's not the platform's fault. They didn't come up with those messages. Those messages have been part of our culture for 400 years. But when you put them in the eyeball of a 9-year-old, guess what? They don't like it. It makes them sad. And so it's not about Facebook or Instagram or whatever platform you want to name. It's us. We have built a toxic culture for our children, and we now have the obligation to teach them how to live in it.
I want to go back to what you said about Nadine Burke-Harris, because it kind of occurs to me that there's probably a lot of people listening that don't even know what the heck we were talking about there. So let me just set it up, and I want your thoughts on this. We wrote about this quite a bit at the time. She was the first Surgeon General of California. Am I screwing that up?
No, you got it.
That's all right. Okay. So she was the first Surgeon General of California, and one of the big things that she did was to develop this adverse childhood experience screening concept. And it got, I think there was some where it's interesting what you're describing now to me is that I think the concerns that some professionals had about that at the time was this idea of taking something that was built to look back and study and project it out on the life of people. But what you're saying is actually the opposite of that. Because in a way, I guess the concern was pathologizing people based on their experience. Whereas what you guys are trying to do was swap diagnosing and pathologizing for simply just recognizing that experience. Right? So it's like maybe everybody got what they wanted out of that exchange, just in California at least. I don't know.
It's a complex one. And I know there's a lot of people on all sides of the story. It's important to note that Nadine is an African-American pediatrician who has done the work and came from Sutter, from the Center for Youth Wellness. She's a warrior. And I think she had seen in her career these things going on in kids' lives. And I don't know if she meant to use her work as a way to open up eligibility for mental health services, but we immediately latched onto it for that reason. And that it was a useful way to help people reframe what was going on with young people. That when tough things happen that aren't your fault. And John, one thing that helps sometimes when I talk to people about this is I say to the audience or to you or anybody else, and I give this framing to Dr. Gabor Mate, who gave it to me. Things happen to us when we are kids that we did not choose. Happened to you, happened to me. We do what we need to survive those moments. And the act of healing is looking back at those behaviors to determine if they still suit us. Are they helping me? Now, for young people in poor communities where it's not safe to go outside or their parents are struggling to make ends meet, it is demonstrated that more stuff happens to them. And therefore, they need additional support. And they don't need to be told they're mentally ill.
Caseworkers are stretched thin, balancing high caseloads and endless paperwork. But with SpeakRight, documentation doesn't have to mean burnout. SpeakRight's protective services transcription cuts paperwork time dramatically, so you can meet deadlines, reduce overtime, and focus on what truly matters, the families you serve. With SpeakRight's free mobile app and desktop platform, caseworkers can capture detailed narratives anytime, anywhere, with just one tap to upload. SpeakRight is proven to lower stress and turnover, helping agencies retain dedicated staff while improving case quality. Don't let documentation slow you down. Let SpeakRight do the heavy lifting. Visit speakright.com/imprint to see how SpeakRight can transform your agency today. That's SpeakRight, SpeakWrite.com/imprint.
So when it comes to what you guys are trying to accomplish, I would imagine just there's probably some more specific benchmarks than what I'm about to describe, but one would assume that if the reform was built around these things, we would now see, or at least be starting to see, a greater percentage of Medicaid eligible kids getting screened. We'd see more kids being eligible, and we'd see I guess what I would describe as a diversity of referrals and routes off of that. So
amen, brother. Yeah.
Why don't you go in on all of that and tell us where you feel like success has been reaped and where there's still a lot of work to be done, or what?
Boom. Well, so those things that you just named have happened. More kids have been screened. More kids have been screened. More kids are getting care. So, okay, that's good. But let me take one step back, John.
Yeah.
The trust really ended up doing 5 things. And I'm going to list them for you.
Go.
Remove diagnosis as a prerequisite for care. Expand the provider class, meaning we added new types of providers to Medicaid: community health workers, doulas, wellness coaches, and certified peers. The third thing we did.
Can you talk about that real quick? What's a certified peer?
It's a 100-hour course where you learn the skills of supporting other people who are struggling with mental health or other social emotional challenges.
Okay.
And you learn how to do active listening, referral, brokerage, care coordination. I'll come back to that one because that's actually, that whole world of the workforce is, I think, the most exciting opportunity in mental health, because there'll never be enough therapists. And I would say, thank God. So that's number 2. Number 1 is remove diagnosis. Number 2 is reimagine the workforce. Number 3 is treat parents with their kids. That refers to this opportunity that we have to provide mental health services in pediatric primary care, because babies don't go to the doctors by themselves. So basically, low-income communities interact with the healthcare system the most frequently in the first 3 years of their child's life. They take them to the doctor 12 times. But the caregiver is invisible to Medicaid because the kid is the identified patient. So we created a way for caregivers to get mental health when they take their babies to the doctor, called the dyadic benefit. So that's number 3. Number 1, remove diagnosis. Number 2, reimagine the workforce. Number 3, create the dyadic benefit or treat parents with their kids. Number 4, make schools automatically in network for all managed care plans. That just went live. It's a groundbreaking play. Basically, we made schools the same as emergency departments. So for 52 codes, health plans must pay for those services. No copay, no cap, no cost sharing.
Well, give me like one hypothetical example where that makes a huge difference.
It's only been live for 6 months, and I think it's fair to call it a shit show. So I just want to say, but kids 8 to 18 use the healthcare system the least. Okay. Like a lot of poor kids never go to the doctor between 8 and 18, except for sports physical or sometimes for reproductive health.
Mm-hmm.
So schools have to become 75% of mental health challenges manifest between 8 and 18. So like, there's no way to address these mental health crises unless we legitimate schools as just as important as a hospital or an ambulance. Okay. But we need to create a revenue model or a reimbursement mechanism that allows for scale. So it's not something you do when the county decides to give you a little bit of money or a foundation says, oh, that's cool. It has to be something that your health plan says, that's so important, I will pay every time you use it. And we leverage something called the portability requirements of Knox-Keene. And so, John, you have a health insurance card in your pocket right now.
I do.
If you go to Montana, to Glacier National Park, which you should definitely do,
mm-hmm.
and heaven forbid you get in a car accident there and you need to be treated, you get an x-ray at the local emergency department. Your health plan does not have a contract with that emergency department. It's not in network. But because the service is deemed essential, the health plan must pay for it. You can't say no. That's what we did with schools in California.
And what are the services that now schools are able to render that are so important? What are, just to give me a couple, give me like.
Yeah, there's 4. They come in, there's 4, exactly 4.
Yeah.
Screening, psychoeducation, care coordination, and master's degree therapy. Those are the 4 sets of codes and those 4 buckets. Screening, psychoeducation, care coordination, case management, and master's level therapy. 52 codes across those 4 buckets.
Mm-hmm.
So a very narrow benefit. But any school, and here's the key part, or their designated provider. So schools who have social workers or school counselors or community health workers who work for the school, they can bill. But the future of this is when we turn schools into a WeWork for community mental health.
Mm-hmm.
So they can invite community-based organizations that they trust and like and think do good work. They can say, hey, blankety blank community mental health agency, you're so awesome. I'm going to put you under my umbrella. And now you can bill every health plan in the state, Medi-Cal and commercial. And they can't say no. It's dope. And it's fair to say the nation is watching. Like I'm now working in multiple states and everybody's being like, how'd you get that done?
the sweet spot will be if that yields big dividends and like tangible health benefits without having some insanely high price tag. Would you agree?
Yeah.
Because that's how big everyone's like, what?
Yeah. Yeah. And so kids,
Seems like it's possible that would be the case.
Absolutely. And the whole cost curve, kids don't cost. Okay. Like hint, hint, breaking news for everybody. Kids are healthy. You can kick them around. They'll still make it to 18,
What's the fifth one? You got to 4. What was
the fifth one I put under, I call it hustle. Okay. And basically what that means is Medicaid is a cost sharing game between the state and the feds. And as long as we don't get per capita cap, as long as we don't get block granted in reconciliation, every dollar a state spends that's non-federal, the feds have to match it. Are you with me?
Mm-hmm.
So you could distill my career, John, to hunting for non-federal dollars to get matched by the feds. Like tobacco dollars, parking tickets, property assessments, vehicle license fees, sales tax. When you're running a big safety net system with hospitals and ambulances and mental health clinics, and you're just always starved for revenue.
I remember an early interview I had with back in the realignment days, I think, in California. And I was asking you about Alameda. And I think this is at the time you guys had been able to really outdraw other California counties when it came to, certain kinds of Medicaid spending. And I just asked you kind of like, what do you do differently? And I'll paraphrase what you said to me here, but it was not with ego. Just you kind of bluntly were like, I've learned how to speak fluent Medicaid. I learned all the nooks and crannies, and the implication obviously there is that your view is that many health departments, whether they're local or state, are run by people that just don't. So that was a long time ago. Do you think that's true today? Has government leadership gotten any savvier in your experience?
Well, I mean, we've shifted a lot to managed care where that skill isn't as important because the dollars come down already matched. So one is, I think,
but
I think, I mean, I need to honor a mentor here, John, Vanna Chavez, who has passed away. She was the finance director of Alameda County. She did not have a college degree. She was born in Hayward. She went to work for Alameda County when women were not allowed to wear pants to work. And she worked her way up over 42 years to be the finance director of a multi-billion-dollar public health system. And she once put her finger on my chest and said, Alex, you have to hustle as hard for federal matching funds as poor people do for rent. If you don't honor their struggle.
That's a gem of a line. So getting back to the original question, I mean, do you feel like people who are in your previous position even know where to look if they are inspired to hustle like that?
No, and that's a little bit why we created it as a strategy. Is we felt we needed to simplify and streamline it, because relying on, it's like when you go to a public school and there's 50 teachers and 10 of them are awesome. If the solution is to make all 50 teachers like those 10, you'll fail. So we needed to come up with some mechanisms that didn't put such pressure on local bureaucrats who, I mean, look, John, man, that job that I had, I did it for 12 years, but man, I think this is a clinical term. Fuck, that was hard. Okay. I mean, I was constantly apologizing for why we couldn't do more. And I knew where hundreds of people were screaming and suffering. And I knew what those rooms smelled like and felt like. And, I wasn't making a lot of money. And my board was treating me shitty. My elected leaders would blame me every time something went wrong. Nah, man, those jobs are I hope there's some local county health person listening to this podcast, because if they are, man, you are doing extraordinarily difficult work in incredibly difficult circumstances. And you have my deepest respect. I've been there, and it's a really, really hard thing to do.
All right. So what do you think you guys did not succeed on as far as the trust and what you guys were?
Oh, yeah.
What's still left out?
Well, I love how you started this conversation because you asked me to dream about a future, which we made maybe some incremental steps towards, but certainly didn't achieve it. So I'm very proud of the policy changes we made, John, and there's actually some operational challenges that really matter, but they're incremental improvements at best at this point. So no, we didn't break the medical model. We created this opportunity with these new provider types to hire tens of thousands of low-income people into our healthcare system and give them family-sustaining employment and reimagine healing. And no, that hasn't happened yet. you know, but the health systems don't want them. The rates are too low to pay family-sustaining wages. But systems change is long and slow and hard. Like, privilege isn't giving up its resources easily. So sharpen your pencils, dig in. And you need reimbursement structures that give you a hope. Like, we don't need any more pretty Christmas tree ornaments on a dead tree. You don't got to send me to do no more pilots. Like, we got to change the opportunity for money, how money flows. That's the crack. That's how you crack the door open. But then you got to go kick it in at the point of service. And that's really what, my new job is about.
Yeah, so that's a good segue. So what's the big stuff that matters with people I trust and admire? Give us some examples of what you're up to.
One of my favorite things I'm doing is actually started when I was leading the Alameda County system. We couldn't staff our ambulances. So we started training kids in detention and coming out of the foster care system. It's called the EMS Core, CORPS. Yeah. We've been doing it for 12 years, 500 graduates. We got invited to Albuquerque, New Mexico by the then director of the child welfare system, a guy named Brian Blaylock. We started an EMS Core site down there with, half the young people are from sovereign lands. And then I got the state of California to put up 24 million. And we got 11 new sites just in the last, 2 months. We've opened Whittier in LA, Oxnard, Riverside. Those 3 sites are up. We opened a site in New Orleans, a site in Newark, New Jersey. Got 7 more sites opening in the next 6 months in California. We're going to train 5,000 young people who face barriers to employment to be real life superheroes. And there's crippling staffing shortages in our 911 and EMS system. They all got jobs already. They can pass the exam. And we're really good at teaching them. So
that's pretty rad. Are there barriers that you have in these various locations to people with a record getting those jobs? Is that something you have to prime or?
Yep. Well, there was a law passed in 2015, which allows us to seal juvenile records. That's a really big deal. There's a bunch of exclusions and appeals you can make. And there's a couple exclusionary offenses, sex offense, lots and lots of felonies will stop you from getting but we do a, DOJ and FBI background check on every kid before we train them on our dime. And if something like that comes up, we tell them. I think that has happened once or twice in more than 12 years of work. Have we found a young person we could not get through the national registry process? It's cool. I mean, look, EMS isn't for everyone, John, like you need, building is burning and blood and guts. You got to be that person. But what we found is that young people who've experienced adversity aren't afraid. And they are disproportionately suited to saving lives. Now, entry-level wages are $22 to $24. It's not so great. But if you stick it out and just show up to work every day for 4 years, you become a paramedic, they'll pay you to train. Then you're talking 100K.
Yeah. There's some elevation.
There's no other career in healthcare where with a high school diploma and a bunch of grit, I can tell you'll make 100K in 5 years. Anyway, that's one example, but we're doing the same thing with the other provider classes, maybe not as successful yet, but we're doing a project in Los Angeles where we're training young people from 14 different youth centers to be community health workers and certified peers, then placing them with the Department of Mental Health and the community-based organizations. That's a big project. And a third one, and I'll stop on this one. When we looked at these new benefits we helped create, what we found was all the money was going to the big health systems. So we got the state to put up $16 million, and we're giving $500K to 34 community-based organizations that work with kids coming out of detention. And so we're giving them each 250 grand a year for 2 years, buying them all an electronic health record and claims engine, getting them all contracted with the managed care plans and teaching them how to bill over 2 years. And these are the orgs who are out there like selling Snickers at Whole Foods, right? Like on the hustle. But a lot of what they do is reimbursable. Like they got a credible messenger or a street outreach guy. Hey, buddy, man, let's get you credentialed as a CHW or a wellness coach.
You don't often think about, or I don't, sounds like you have, workforce development as a mental health strategy. But that's your thing now.
Amen, brother. So one is I'm going to work with people I trusted in my own things that matter. One. Two, I'm going to continue to do Medicaid systems change, particularly at its nexus with child serving systems, because it's a great way to change foster care and juvenile justice. And third, I'm going to run workforce programs that redirect the economic benefit of safety net systems to the people they were intended to serve. Because I know for a fact that of all of the families and kids I've served over 30 years, almost all of them needed a good job more than they needed a good therapist. Like financial justice is a healing art, man. People will solve their own problems if they can make ends meet, if they have meaning and purpose. But our culture robs it from them, demeans and diminishes them. But if you've talked to people like me who've done the work for a period of time, you will find great respect for poor people. And I think they're an untapped resource in reimagining how we heal.
I'll get you out of here on this because I know you got to go to another meeting, but I would be remiss not to ask a Medicaid expert such as yourself about what's going on in Washington. You know, one of the looming spending battles this year is going to be over Medicaid because budget reconciliation rules in the House included instructions for the Committee on Energy and Commerce to cut back $880 billion, I think, for, over a 10-year window here. We were talking about it a little bit before you jumped on with me, and you described the real boogeyman in this when it comes to kids as the per capita cap or a block grant. So why don't you just, if we could close out on just explaining why that's the thing keeping you up, and maybe if you want, what recommendation do you guys have? Do you have for these guys to find cuts elsewhere? Keeping this.
Well, John, I mean they're going to reduce FMAP, the percentage of every dollar they pay for. They're going to put work requirements on. They're going to come after some of the tricks we play to get extra federal matching funds called supplemental payments. They're going to try to penalize states like California that cover on docs. They're going to make it, you have to redetermine more often, age-old trick for cutting the rolls.
Mm-hmm.
And those are all sucky, okay? Every single one of those are unconscionable. And, and fuck those guys, okay? But the one that will be harder to come back from is this thing called per capita cap, where basically the feds set a number at which they won't spend more of per person. And per capita cap is a fancy way to talk about a block grant. And what makes Medicaid and kids so unique is that uncapped federal entitlement that exists, meaning when the state spends it out, they can get a match. So the feds turning the spigot off basically freezes our system at its current scale and scope. And no one is suggesting that serving 4.7% of kids is anything close to what we need to be doing. Like, even if you want to use the same old messed up model, we got to do at least twice and probably 5 times as much as what we're currently doing. And if you take the Fed money out of that, it's a heartbreaker. So again, there's going to be some major things that I think amount to, 20 billion in cuts. And California's Medicaid program is 170 billion. So that 20 billion will suck, and people will suffer. And I think we can come back from it, in part because Governor Newsom wants to be president, and he might invest in at least trying to backfill some of it. And maybe we can cut and move and shift. But if you block grant it, we're kind of dead in the water in terms of future looking.
So in a world where there was a per capita cap, it may be the case that something like EPSDT requirements survives as a rule, or the eligibility for all foster youth survives, but there would be a ceiling on which they would on the expenses you could spend on any of it.
Yeah. I mean, it'd be eligible, but eligible for what?
Right.
Yeah. It's a big deal. Like that's the one. And I don't think there's support for it because, it would mean curtailing and closing a lot of children's hospitals. Its impact for homeless kids, for foster care kids, for juvenile justice kids, for kids in special ed would the implications of doing it are so drastic and dramatic that I don't see it happening.
Yeah, I mean, do you think that the cuts would be so substantial in such a structure as to ripple out into health services that, not to put a too blunt point on it, middle income and wealthy people rely on?
I don't know.
Yeah.
How to save money on the adult side in 2008, you learned it. You cut the dental benefit, you cut the podiatry benefit. You probably roll back some of the coverage of on docs. There's other things you can do. For kids, do we really have the stomach to do those things in this culture? I sure as hell hope not.
Alex Briscoe, formerly of the California Children's Trust and head of the Public Works Alliance. Thank you very much for joining us on the Imprint Weekly Podcast.
Hey, thanks for having me. Take care, John.
Thanks to Alex Briscoe of the Public Works Alliance for joining us today, and thanks to Listen for sponsoring this episode. The Imprint Weekly Podcast is a production of the Safe Camp Audio Network, which is a division of Fostering Media Connections. Please visit safecampaudio.org on the web or at Safecamp Audio on all major social media. This podcast is produced and mixed by Christine Anjoko with music by Luke Giroux and Cyrus Elia. If you enjoyed this episode, we would love it if you would consider subscribing or giving us a 5-star rating on Apple, Spotify, or wherever you download your podcasts. We would greatly appreciate if you would consider supporting our work here on the podcast and in print. Small donations from our listeners and readers go a long way towards helping us grow and cover more great stories in child welfare and youth justice. To support us, it is super easy. Just visit imprintnews.org/donate. You can follow The Imprint on Twitter and Facebook by searching the handle @TheImprintNews, and you can visit us on the web at imprintnews.org or email us at tips@imprintnews.org. I'm John Kelly, and we'll see you next week.